Diagnosis. It is impossible to make a full diagnosis of renal tuberculosis without the ureter catheter. The diagnosis must cover the following points. 1. The presence of urinary tuberculosis. 2. The origin of this tuberculosis in the kidney or in the prostate. 3. If in the kidney, which kidney is involved. 4. If one kidney is involved, what is the condition of its fellow? 5. Are there active lesions of tuberculosis elsewhere? The suspicion of renal tuberculosis is aroused whenever there is spontaneous cystitis or prolonged pyuria, or bleeding great or small in a relatively young person. This suspicion is strengthened if the urine is acid, free from bacteria, yet purulent, and contains a trace of albumin and microscopic or macroscopic blood. If the tubercle bacillus is found in the urine, see below, the existence of tuberculosis somewhere in the urinary organs is proven. The palpably large or tender kidney may be tuberculous, or it may be hypertrophied or hydronephrotic, or it may be the hypertrophied or hydronephrotic opposite kidney. If the radiograph shows a marked difference in the size of the two kidneys, the large kidney is usually the normal one in compensatory hypertrophy, for tuberculous pyonephrosis is usually small. Such are the hints. The proofs follow. The tubercle bacillus. In order to minimize contamination, especially with the acid-fast smegma bacillus, the urine should be drawn by catheter from the bladder or the ureters. Bladder contamination with smegma bacilli is said not to be possible. Yet I have twice been temporarily misled by the report of acid-fast bacilli morphologically resembling the tubercle bacillus obtained from bladder urine, and reported by a laboratory of good repute. So far as I know, this mistake does not occur if the all-night decolorization is employed. In early and active cases, the tubercle bacilli are usually found readily and in large numbers. But in all cases, it may be difficult to identify them both on account of their scarcity and on account of mixed infection, nephritis, etc. The antiformin and other methods of cleansing the urine are of some assistance in obviating this difficulty. The best method is probably that suggested by Crabtree of centrifuging a number of tubes full of urine at the usual 300 revolution rate for 3 minutes, thus throwing down practically all of the pus, then centrifuging again at 1,000 revolutions until the urine is clear, thus throwing down the bacteria relatively uncontaminated. Were it not for the delay involved, the accuracy of the guinea pig injection test for tuberculosis would make this the test of choice in all cases. But 2 or 3 months is a long time to wait for a diagnosis, and though this period may be shortened by various devices, such as injecting the urine subcutaneously in the thigh of the pig and bruising its inguinal glands, these devices are not regarded as entirely safe by the best laboratory workers. With typical clinical history and cystoscopic and ureter catheter findings, the usual overnight stain suffices for a diagnosis. Indeed, even the guinea pig may err. I've had 2 cases in which the temporary closing of the renal focus of infection permitted negative guinea pig reports, which were subsequently repudiated by relapse of symptoms, correct diagnosis, and nephrectomy. Cystoscopy. The alert expert will not fall into the error of considering every patchy or ulcerative cystitis tuberculous, nor will he believe a kidney tuberculous because its ureter mouth is inflamed, for the kidney above may be normal, or ulcerated, deformed, or retracted, for the kidney above may be the seat of non-tuberculous inflammation. Indeed, there is nothing absolutely characteristic about the appearance of a severe tuberculous cystitis, nor anything to prove that it is derived from a primary lesion in the prostate or in either kidney. Early cystitis is often more suggestive in that it shows a strikingly patchy distribution of lesions, their tendency to group in the region of the ureter affected, and the appearance of characteristic little nodules, the so-called tubercles. Tubercle bacilli without pus. Although pus, and even bacilli, may be absent for brief periods from the urine of patients with small surgical lesions, the presence in the urine of bacilli without pus does not establish the existence of renal tuberculosis. Sufferers from advanced pulmonary tuberculosis often deliver bacilli in the urine, though subsequent post-mortem shows no renal lesion. Excision of a piece of mucous membrane. When the tubercle bacillus is not found in the urine, a positive diagnosis may often be made, as suggested by Berger, by microscopic examination of a piece of mucous membrane removed through the operating cystoscope. But the localization of the lesion and the establishment of the condition of the opposite kidney require ureter catheterization. Ureter catheter diagnosis. The catheters are introduced into the renal pelvis in order to estimate the presence of retained urine there. The first urine obtained is discarded in order to avoid contamination with pus that may have been picked up in the bladder. The next few cc's are employed for the usual urea and microscopic examination, following which the intravenous phenylsulfonephthalene estimation is made. In early cases, a distinct polyuria from the diseased side will be noted, the increase in quantity being sometimes sufficient to counterbalance the lowered urea percentage, so that the total amount of urea secreted at any one time by the diseased kidney is greater than that secreted by the normal kidney. But the phenylsulfonephthalene output is much more markedly interfered with and clearly shows a deficiency on the side of the diseased kidney. Only once have I known this to fail. 6 months later, a second cystoscopy showed a distinct, though slight, falling off of phenylsulfonephthalene output, and nephrectomy revealed a destruction of a single papilla by tuberculosis. In these early cases, the tubercle bacillus is usually readily identified. When the disease is further advanced, one recognizes readily enough the presence of pus and the marked lowering, both of phenylsulfonephthalene and urea output. But the identification of the tubercle bacillus may present considerable difficulties. In such cases, the excision of a piece of vesical mucous membrane is likely to prove useful. When the ureter mouths cannot be found, intravenous injection of indigo carmine is a great help, both in suggesting which is the more normal kidney and in aiding the passage of the ureter catheter. Difficulty in cystoscopy, due to the great sensitiveness of the bladder, must be overcome by various forms of anesthesia. General anesthesia is most inadvisable. The recovery from ether, given for the purpose of cystoscopy, is much more trying and dangerous than when the ether is given for the purpose of nephrectomy. For in the latter case, the patient is at least relieved of his toxic focus. I have employed spinal anesthesia with great satisfaction, but have had no luck with sacral anesthesia. My present preference in the management of these cases is to administer hyoscine and morphine, then an intravenous injection of indigo carmine, and a local anesthetic. I then employ the 18 French single catheter cystoscope, direct this immediately toward the ureter mouth, from which I expect to see the blue stream issue. If this appears, catheterize that ureter immediately without looking for anything else. If it does not appear, turn immediately to the other side and catheterize that ureter. By this combination, anesthesia and the use of a small cystoscope, a skillful manipulator can catheterize one ureter with scarcely more pain than would be involved in the introduction of a catheter. Unless the patient is unusually intolerant, the cystoscope may be left in place so that through it, the water in the bladder can be drawn off as it accumulates for comparison with the urine obtained through the ureter catheter. If all these means of diagnosis fail, we must await the guinea pig for an absolute diagnosis of tuberculosis. Once this is obtained, if there is good reason to believe that one of the kidneys is normal or relatively normal, the selection of kidney for nephrectomy may be entrusted to exploratory operation. It may be necessary to disclose the surface of both kidneys completely, or even in some instances to palpate both ureters before the diagnosis can be made. A tuberculous kidney always shows a relatively thickened ureter. Other means of diagnosis. There are many means of diagnosis of secondary importance as confirmatory of the findings enumerated above. Among them, the following may be mentioned. The thickened tuberculous ureter may often be palpated through the vagina. I have once known a competent urologist to feel such a ureter very distinctly when it was not there. Pyelography outlines very distinctly the deformity in the kidney pelvis produced by the destruction of tuberculosis, figures 93 to 96. But tuberculosis is one of the conditions in which I feel least faith in employing pyelography. The radiogram without pyelography does not distinguish between the shadow cast by a cheesy kidney and the shadow cast by a hydronephrosis, plate 16. The tuberculosis complement fixation test for urine is highly spoken of by Heitz-Boyer. I have vainly tried to duplicate his results. Beer places much dependence upon the diagnostic tuberculin injection to identify the presence of tuberculosis in the body. A focal reaction consisting in pain and tenderness, and often an increase of tubercle bacilli in the urine, identifies the situation of the lesion. He believes the drug safe if used with proper restrictions.